Thanks, David. And I want to thank everybody for taking the time to be with us today. I realize everyone has a very full schedule, but we're really grateful that you're participating today because it gives us an opportunity to hear what concerns you, the kinds of questions you might have, some of the input that you could provide, and perspectives that sometimes elude us because we're biased by the fact that we're part of the process. And in that sense, again, I would appreciate you being candid in your questions and provide us whatever feedback we should know about moving forward. We're trying to make the programs better, and we really value your perspective. For about 15 minutes or so, I'm going to share a brief PowerPoint for some background, and it might prompt some questions that you might have or some things that you hadn't thought about, but I want to make sure that I share my email as well, because if something comes to you tomorrow or the next day or next week and you didn't think of it during the presentation, don't hesitate to reach out to me. If I don't know the answer to the question, I will find someone who does, and we'll get back to you. So let me, and I'll show my email again at the end. So if as I say, if things come to you, come to mind, feel free to reach out at any time. This is focused on diagnostic radiology and interventional radiology, and we'll be mostly talking about initial certification, and along those lines, we'll be talking about the how of some of our exams, especially in a remote environment. How do they work? What does it mean for you as a candidate or as a faculty member? And we want everybody, I think, ultimately to be comfortable with the process. But first, we're going to talk a little bit about the why of board certification. Why become certified at all? Why does the board exist? Why do any of the boards exist in surgery or pediatrics or internal medicine, et cetera? And it really gets back in some way to our mission. And this is our mission statement. It took about 25 of us 8 hours to come up with these couple of dozen words. This was about 8 years ago. And the first version of this didn't have the word patients in it. It really was, I think, a little skewed more toward the radiology professionals, the doctors. And after some discussion, we kind of said, well, look, if we didn't have patients, we wouldn't need board certification. We wouldn't need to distinguish ourselves in some way as different, as highly qualified and experienced professionals. So in that sense, I think it's useful for us quite often to remind ourselves that a lot of what we do is really geared toward helping the public and the patient. And we hope along the way that we provide significant value to the professionals in radiology, obviously also radiation oncology and medical physics. And it's based a little bit on the fact that some professions are different. And I'll put this in two contexts. One is they have an element of public trust, and that is that the public or the patients that you serve, they trust that you are highly qualified, and they trust that you endeavor to do the best that you can do. And then I'll add to that the fact that within that sort of trust element, there's a sense of purpose, that what we're doing is important, and by extension, it's important to do it extremely well. And these things are parts of the reasons as to why there is a board certification process. Why is there this philosophy that says we're going to push ourselves to be as good as we can be in the provision of care to our patients? Now, there's a history to the boards that I confess I didn't know when I was actually taking my exams some years ago, and that really is because I didn't know what the nature of the board was, and I thought it was something the government had decided to do, or consumer group decided to do, or some sort of regulation was responsible for. The fact is the boards were formed by the professions themselves, and this goes back to the 1920s and 30s. And just as an example, picking on the American Board of Surgery, which was actually incorporated just a few years after the American Board of Radiology, and it was established for this reason, that is to, with the goal of distinguishing certain professionals who, through their training experience and the fact that they passed an examination, met the highest standards that were defined by the board. So here was the profession itself said, we're going to come up with some way of distinguishing ourselves. Surgeons, that is board certified surgeons, is different from other people who might claim to be surgeons because there was no rigor around what it meant to become or to practice as a surgeon. This is from a different specialty. This is from pediatrics, and they pointed out that, again, giving kind of this historical context, that in the 20s and 30s, if you wanted to be a pediatrician, all you had to do was put up a sign that said you were a pediatrician. And obviously today we don't have that, right? We're going to, we have the opportunity to be board certified, that is to distinguish ourselves because of a rigorous set of requirements that documents the level of achievement that we've attained. And again, I think it's important that this is not something that was hoisted onto us by the government or anyone external to the profession. This was the profession itself. I had the opportunity a few years ago to ask the former CEO of the American Board of Medical Specialties, who deals with all 24 of the member boards in specialties as diverse as colorectal surgery and preventive medicine, et cetera, but obviously includes radiology. And I said, what mistakes do boards make? And she said there were three things, and the first was ignoring the doctors. She said, you got to listen to the doctors. And I said, well, that makes sense, and that's part of actually what we're doing this afternoon, right? We're listening to the doctors. And then she said, don't expect too much of the doctors. And what she means is in terms of process, and that is that we certainly can expect a high level of knowledge and skill, but as far as the process itself, we need to make sure it's simple. But by extension, she said, well, the third mistake was expecting too little of the doctors. Now, here again, she doesn't mean process. What she means is it has to be a credible process. It has to be something that really speaks to this high level of achievement, knowledge, and skill that really distinguishes the profession. So if it's too easy, if board certification were a matter of taking an open book 50-question test, we'd all say, well, that's too easy. That's not credible to the public. Therefore, it really shouldn't be used to distinguish qualified people from those less qualified. And these things sort of I find very useful when we're doing our day-to-day work here at the board. We're interested in making sure that we're doing these two things. I want to make sure we're not shying away from the opportunity to listen, and especially listen to our critics, people who point out that there are things we could be doing better. Secondly, we shouldn't be expecting too much in terms of the process itself. We should make it simple and streamlined. But at the end of the day, we really have to make sure that what we're doing has some rigor behind it so that it's defensible as a credential. Now, I'm going to say this a slightly different way. So what we need to do is we need to control costs, and we need to provide relevance. We shouldn't be too demanding, already alluded to that. So we need high standards, but the processes themselves shouldn't be onerous. And at the same time, we can't be too easy, meaning that the exam has to be a challenge. It has to be something that, again, is commensurate with the level of work and experience and study that went into doing it. Lastly, and we emphasize this every day at the board, and that is to enhance service, which I think, for lack of a better way to summarize it, means better communication. We need to be better at making sure people understand the why behind what it is that we're doing, which is part of my emphasis during this part of the presentation. We get this question a lot about does board certification mean anything? This is from 2004, but since that time there have been dozens of papers that have examined whether or not board certification matters. I admit this is usually from the internal medicine, family medicine, and pediatric areas, because there are far more diplomates in those areas and far more practitioners, and they have a control group that we struggle to find in radiology, because almost everybody who's practicing radiology, in fact, is board certified. So it's hard to establish control groups. So this isn't excellent science, because I think excellent science in this area is difficult to do. How do you control for every variable except board certification? That's very hard to do, especially in radiology. Not to say we shouldn't try. We should be examining those opportunities to demonstrate that board certification matters. But the reality is an awful lot of it is intuitive, kind of getting back to this idea of what's the public's expectation of what we're doing. And what the public expects is you should be doing as much as you can possibly do to distinguish yourself as someone who is qualified. And obviously I'm over summarizing just in the interest of time, but that is a lot of what goes into this intuitive sense of that board certification matters. Daniel Pink, I think, summed it up well for most professionals, probably in medicine altogether, but I would argue it especially applies to radiology, and that is that individuals are really after three things: autonomy, mastery, and purpose. and arguing that it is self-directed. It is really about being better and better at what you do, and being able to, again, to make sure that that fulfills those sort of obligations as part of our social contract to the patient and to the public. So just a way to sort of summarize what it is we're doing. I think the ABR is again operating on just a few basic principles. We realize the value of board certification is proportional in some way to the rigor of the process. If we don't self-regulate as professionals, someone else might step in and do it. And my personal preference is I'd rather the government didn't define for us what constitutes a quality radiologist, for example. And then in addition, just from a practical basis, we're trying to be relevant and reasonable in what we ask of the candidates and diplomats. So that's kind of the why for board certification, the kinds of things that we think about when we're making some of the policy decisions we come up with. But let me get into the how, and this really is about the exams we administered in 2021, because that was a catch-up year, right? We had to do the 2020 candidates because essentially no exams were given in 2020, and we also had to make sure the class that would have been eligible in 2021 was also examined. So we gave twice as many exams as usual, more than 5,000 computer-based exams, more than 1,000 oral exams across all of our disciplines. And I think there was a time when we'd say, well, why did we make this change? I think this is pretty obvious to most of us. I mean, there were constraints that impacted all of you on this call to one degree or another. There were travel restrictions. The commercial test centers, which we had used for medical physics and radiation oncology, had limited capacity because of the pandemic. And there were distancing considerations even at our own test centers if we had been allowed to reopen them. For example, our test center at the time that we had in Chicago. So all of these things meant that we had to make a change, and we borrowed from models used by higher education and introduced remote exams. And we did it fairly quickly because no one was sure when the pandemic was going to end. And I think many of you probably shared the same sentiment I did in March of 2020, kind of saying that in a few months this will be back to normal, and realizing, of course, very slowly, but somewhat emphatically, that we were just wrong about that. And in that sense, we pursued this not knowing when things were going to get normal enough that we could return to the model that we had been using for a secure, high stakes examination that would allow people to progress along the path to board certification. That gets me to another point, and that is we didn't design the remote exams as a temporizing measure. We said, no, we're going to go ahead and make it so that it works, acknowledging the second bullet here. It depends on whether or not it's successful, and it turns out it has been, I would argue, highly successful, not perfect, and it needs some improvement, but highly successful. We have more than 99% of our candidates who start an exam, finish the exam the same day. And so I would argue it works. We just want to make it better. I want to make the experience better for the candidates. But it gets back to this concept, every exam is a pilot, meaning that we learn as we go, and we're going to make it better, but at the same time, there could be issues that come up where we might have to return to a non-remote exam. I think that's highly unlikely. Our plan is to continue remote exams indefinitely so that candidates don't have to travel. They can avoid the expense related to that and the stress of having to fly to another city to take an exam. And in addition, we acknowledge that there are just, I think, stress reducers that go along without having to travel where you can take the exam in your own environment. There's a longer version of this presentation where I go through the first 4 elements of how we went about designing the remote exams, but I'm going to skip those. We're going to emphasize the 2 that are really important. I mentioned a moment ago, candidate experience. That is the ability to take breaks during the day because it's flexible, the ability for us to recover disruptions in your internet connection and be able to give that time back, our ability to accommodate both people with disabilities, but also for nursing mothers, for example, so that this experience should not be the thing that you dread about it. It's hard enough studying and preparing for the test. We should make all these other things as streamlined as possible and as user-friendly as we can make them. Now, having said that, we still need a valid exam, and that actually relates to the first bullet, which is the security. It has to have a certain level of security about it, and it has to be fairly rigorous, as I mentioned a couple times already, because we want it to be indicative of a high level of achievement and accomplishment. The location for the exam, I think many of you probably already know this. There's some very minimal requirements. You have to have an adequate internet connection. The work area, the testing area has to be private and free from interruptions. And the couple examples we use, if you're alone in a room in your home or office, that's fine. But don't take it at a Starbucks, right? So we need some reasonableness about that environment that you're in. We did have actually a few candidates where a family member would walk through, they were taking in their kitchen or something, a family member would walk through. That's not a problem. We're not worried about that. We're worried about conversation, basically, right? If you were in a group setting at your hospital, that wouldn't be acceptable. But most people were able to not only find a place to do it, I think it worked out well for almost all of our candidates. The work area itself has to, of course, be demonstrated to not have books or notes or a second device that would change this from a closed book test to an open book test. Obviously, we have to acknowledge that as well. Now, if you do lose your internet connection or your hardware locks up, etc., we have ways to deal with that. Our remote proctor vendor that helps us with the security piece is sometimes a barrier to that, but in general, we're able to intervene, and our staff is very good about giving time back. So short outages of a few minutes are not a problem. Longer outages, we have recovery plans for that too. Rarely, as I said earlier, does a candidate start the exam and not be able to finish it. And the only real change in the exam model is that one of the sort of prices that we have to pay for giving a remote exam is that we ask candidates to answer questions in blocks, because once you leave to take a break, for example, in effect, that security is broken. We trust you, but at the same time, we don't want people to be tempted to look up an answer to a question they just saw and then come back to that and say, oh, you know what, C is probably a better answer than B. We really have to make sure that people aren't tempted to do that. So as a result, the biggest change in actually the way the exam platform works is that once you take a break, you basically said, all the content I've seen up to this point, I'm comfortable that I've answered it the best I can, and I'll come back and pick up where I left off if I take a break for a sandwich or a bathroom break or whatever it might be. The technical check options, I include this slide because we get this question a lot. Can people familiarize themselves with the platform? Can they make sure that their hardware works, that their network is adequate? And all of these things can be done. Not only can you do it, you can do it multiple times. And you can go in and check. In fact, we strongly encourage that individuals take the practice content and do the technical check on the same piece of equipment and in the same network, on the same network that they intend to use on exam day. But it allows everybody to practice it. And the goal here really is to make sure that when you sit down for the exam on exam day, that you're familiar with it, that you're comfortable, that it's not a test of how well you learn the software or the hardware, but rather, those things are already familiar to you. Now we're just trying to test the extent of your knowledge. And that's really what we want this to be, is that anxiety is gone because you know exactly what you're walking into, because for the couple of weeks leading up to this, you could have practiced it 5 times a day if you wanted to. I think 3 or 4 over that week or so would be just plenty. But bottom line is we want you to be comfortable with it because we want you to succeed. We actually want people to pass the exam. That's a good thing. It again indicates a high level of achievement. Now, a couple things unrelated to exams. I'll just go through these quickly. In late June of last year, July 1st, effectively, we introduced a rather liberal residency leave policy. Now, you still have local institution limits that are practical and reasonable, but as far as your board eligibility, provided you took off an average of no more than 40 days per year during your residency, you will be considered board eligible based on successful completion of the program on June 30th, meaning the expected graduation day. So the point is that there are limits on how much time you can take off and still be board eligible, but this is one of the more liberal policies among all of the boards. We also introduced, starting in just in a couple of months, the additional IR certifying event. We hadn't done this, in fact, for our IR, I don't think it's ever been done, but even for the other disciplines with an oral exam. It's been many years since we had a second oral exam in a single calendar year, and we'll be doing that indefinitely, provided again that it works. But as it stands right now, we have a limited capacity additional event in spring of this year in April, and then the main event for interventional radiology is in the fall. And as I say, we're still refining that. The idea here is so that individuals with life events, and especially the one we hear the most about is childbirth events, that those individuals have a second opportunity, so that if they missed one, they don't have to wait an entire year. There's at least a chance we'll be able to fit them in this interim exam, which, as I say, in this case is kicking off just in a couple of months in April of this year. And just to be clear, the candidates who are eligible for the April exam were eligible last year as well, because eligibility starts for this exam on completion of training, which of course typically is June 30th of the academic year that you're finishing up. We expect to refine and simplify the computer-based exam platform. It'll look about the same, but we hope that with these refinements, we'll have less technical challenges for individuals as they try to navigate through the software. And we're also looking at introducing more communication channels in 2022, including things like this. We have historically only done town halls in response to a specific event or policy issue. We're going to do them routinely, and that's what today is all about. It's open forum. You can ask us whatever you'd like. We want to hear from you, as I mentioned earlier. We also sent out a communication survey. I hope many of you responded to that to let us know, how do you want us to communicate with you? And is email better than text? Is text better than email? Should we be using social media more? So those kinds of things we hope to learn from a survey that we sent out to actually all of our candidates and the diplomates in continuing certification. Last thing I just want to talk about, we just recently formed a DEI committee. It's a committee of both the Board of Trustees and the Board of Governors. And the main focus is really related to exam fairness, to make sure that there aren't biases that are related, especially in the oral exam context. But secondarily, we're looking at all the activities of the board, including those related to diplomates, volunteers, and our staff, as well as the public. So that's just getting momentum now, more to come in that regard. But obviously, it's important that we recognize where that might impact our stakeholders, including our exam candidates. So with that, I'll close. I'll leave my email for just a moment. Thank you again for being here, and I will turn things over to David to start the Q&A. So thank you again.
Thanks, Dr. Wagner. So yeah, again, just a reminder, if you do have questions, go ahead and type those into the Q&A section of the webinar, and we'll start taking some of those and addressing them from the panelists. So first question that has come in is, will there be a second test date offered for the DR certifying exam as well? Dr. Wagner, can you handle that one?
Yeah, I can take that one. We're looking at that possibility. It's actually more expensive than you think to produce exam content, and the committees that do this are made up of volunteers, so they don't get paid. But in terms of the effort that it takes to create high quality, unique exam content, it's a struggle, and we have to do it, of course, across multiple. For DR certifying, we have to offer, for example, 3, we technically call them modules of GI content, for example, and in order to create an exam of that breadth and depth, it's very hard to do it twice. Having said that, it is something that has gotten discussion at the board meetings recently. Is there a way we could refine this so that we could offer a second DR certifying event? As it stands right now, it's on the table. It's just going to be a bit of a challenge to basically produce a second set of content each year. Don, do you want to add to that? Did I cover that correctly?
No, you covered it correctly. So the challenge is developing the content, and not so few people need the second date. That's historically that's been the issue. The cost for the benefit isn't there.
Great, thank you. Another question is, how is the passing score determined for the core exam? Dr. Fleming, you want to handle that one?
Sure, it's a criterion referenced, so it's a Angoff standard. What that means is that a group of people got together, looked at items. They did it as a panel where they were looking at items and trying to visualize, would a resident in my program that is minimally competent get this exam question right or not? And they would score that item in that Angoff panel, and there would be a varying opinion about whether it was difficult or not. But there would be a mathematical number that could be derived from that effort that establishes how many questions you have to get right within a test to be able to pass. So everybody can pass and everybody can fail. So there's no percentile cutoff score. There's no attempt to even do that. It's just basically trying to establish a score of minimal competence.
Yeah, and I'll just add to that, that on a practical level, Don and I were part of a webinar last week that I think skirted around an issue that, while obvious to us, was not necessarily obvious to everyone else, and that is that rarely do people who pass the test, extremely rarely, actually fail to pass all of the sections. The performance is fairly consistent from one area in the core, pediatrics versus GI versus ultrasound, et cetera. And in some ways that's reassuring to me because it says that it works, meaning that your competence is that Angoff method Don described is incredibly robust in the way that it works to allow us to not grade on a curve, for example, because we don't do that. We don't have a set number in our head that 15% of people have to fail. Instead, what we say is that anybody who's competent, as Don said, it could be 100% that reach that standard, but it performs extremely well internally because it's very consistent across content areas. And then for a given candidate, the candidates who do well, do well. They're well prepared. They studied, and it's not a question of sort of gaming the system to kind of say, well, I'm going to concentrate on these areas because others don't matter. The fact is, almost everybody passes everything across the board.
Great, thanks. Next question that's come in is, will there be a sooner chance to take the DR certifying exam? In other words, sooner than 13 months after the completion of residency? Dr. Wagner, you want to take that one?
I was hoping you were going to give that to Dr. Fleming or Dr. Donick, so yeah, I'll take that one. That model's been around for a while. I think the debate at the time was that to ask a candidate to take the exam during a fellowship, and obviously I'll get this number not quite exactly correct, but let's say 9 out of 10 radiology residents go on to fellowship, and some years it's more than that, some years a little bit less. But to ask them to do that during the fellowship year was probably not reasonable, and the decision was based on this idea that whether it was an ACGME fellowship or not, the reality was that that level of specialization that went along with many fellowships was going to be part of the assessment that was going to be done. So right now, that's why the construct is built that way. I don't know. You could debate that it could be personal choice, but that's why it was constructed the way it was. At the time it was done, many boards, of course, have to wait even longer to become board certified. But Reed, you were part of that group that made that decision. Am I leaving something out that was part of that determination?
Yes, and there's a second part of that as well. The fellowship program is designed to give that fellow added training and experience, and they really don't want their fellows studying for the certifying exam when they should be trying to learn the material in the fellowship. So it really benefits both to have that separated.
Great. Thank you so much, both of you. Another question that's come in here is, what are the most important things to do to prepare for a remote ABR exam? And I think I might ask Dr. Cruz and Dr. Bailey to each respond to this particular question.
Sure, I can start with that. I took the remote DR core exam last year. I would highly recommend doing the practice test. I think I did it 3 or 4 times just out of anxiety to make sure that I was familiar with the platform and had tested the station that I was going to use it with. I think that helps a lot with exam day jitters and just taking that out of the equation. Other than that, obviously studying the material, I don't think that preparation has really changed, but yeah, I would just really strongly encourage using that practice exam.
I would second that. I personally did not take a remote type of exam. Mine was in person, the written, I guess, format and the oral exam. But I think familiarizing yourself with how it's going to be structured and laid out, kind of like signing in ahead of time just to make sure your network works, your computer works, that'll take away a little bit of anxiety because you just don't know what you're going to get into. The practice exam is like a good kind of model just to kind of get a feel of what may be asked of you. For my trainees that I am involved with training, they agree with those statements and also kind of what we just heard from Danielle. So I'll just leave it with that.
David, I think those are very important points because we want to test what the candidate knows about radiology, not how facile they are with their technology.
Exactly. Great point. The next question, and I'll ask Dr. Spies to address this one, is do ESIR residents need to take both the DR and the IR-DR certifying exams?
No, one or the other is fine. Of course, if you take the DR certifying examination, you'll be DR certified. It is not a prerequisite to take that in order to take the IR-DR certifying examination. There used to be an argument for taking both, and I think Chris was probably in that window, in that you could get DR certified more quickly, and then you would have the opportunity of taking just the oral examination. So if you happen to be DR certified and you qualify to take the IR certifying examination, all you would have to do is take the oral examination. But now that we are past the fellowships and we now are into the era of IR graduates, you are board eligible or able to take the certifying examination essentially immediately after you graduate from residency. And the first opportunity is 3 months later. So there really is not a compelling argument to get DR certified. The DR and the DR-IR certification is a joint certification. You are fully certified in DR and you're fully certified in IR. And so there is not an added benefit. You're not going to have 2 certificates hanging on the wall next to each other. And in fact, if you want to go from DR certification to the IR-DR certification, you actually give up the DR certification and then you get converted to a joint. So I think at this stage, the simplest thing for people to do is to take the DR-IR certifying examination. That really, and Chris, you can comment on this because you've been very active in this area. I don't see any strategic advantage in having a DR certification ahead of time.
Yeah, just for the audience, I completed a fellowship in VIR, so pre-IR residency. And after I completed fellowship, I just wanted to become board certified, kind of get that off my shoulders. So I actually took the DR certifying exam. At that time, it was on computer in Chicago. And and I felt like a weight was lifted and I didn't have to worry about it. That was just my own personal experience. My co-fellow actually waited and kind of let it linger for a while, and maybe more anxiety provoking for him, but to each their own, I guess. I do wonder, would it cost more if you did it both ways as well? Would you be getting DR certified now, have to pay for that exam, and then redo and kind of do the IR/DR way, if that was allowed? I would think that might cost 2 admission fees. Maybe you guys can comment on that.
You can clarify, David, maybe, but yes, there are 2 fees if you take 2 examinations. And of course, the oral examination is a separate entity. The other thing I would just comment on is it used to be, and I think this is probably the case when you took it, when it was in person, you'd take the computerized examination, the portion of it, the same day, either in the afternoon or the morning, and then you take the oral examination. Since we're now in a permanent, or we think at least a permanent remote setting, we have decoupled those 2 examinations. So you don't take them the same day. In fact, there's really no opportunity to take them the same day. So normally there would be a written certifying examination for both DR and the IR portion of the certifying examination. Usually now I think it's early September, and that you have to take, and then separately you have to take the oral component, but you don't have to take them in that order. And I think some people would like to split it up now, and maybe they would want to think about doing, the oral examination 6 months later, because they can concentrate on one thing at a time. Just to also point out, if you take the DR certifying examination, you have the essentials of radiology and 3 modules that you have to take in diagnostic radiology of your choice. If you take the written component of the IR examination, it is the essentials of radiology and 1 IR module. So it's a shorter examination for those who are taking the combined IR/DR exam.
Thanks. Another question regarding exam dates. When will exam dates be available for the 2023 calendar year? Dr. Wagner, can you handle that one?
Yeah, actually, it's the kind of question, David, I would ask of you. So, but I'm glad to. Our goal is to get those out next month, and I believe it's going to be in the first half of the month. Is that correct, David? Like I said, that's the kind of question I would check with you on. But I think we're poised to release those probably in the next 2 weeks or so.
Yep, they are just about ready to be released. We're still working out some fine details, but they're just about ready. So yeah, it should be no later than the middle part of March. All right. I don't see any additional questions showing up at the moment. Are there any other particular topics or comments that the panelists might have that they think would be helpful?
Well, one common question, David, is how do you best prepare to take the examination? And there are many approaches that residents often take, but I've seen at least one paper looking at this and coming to the conclusion that the best preparation is to continue to do clinical work on your clinical services. That is, see a lot of cases, obviously supplement that with reading, but focusing on clinical work rather than board review sessions or more specialized study.
I was going to add something to that too. When I was a first-year resident, my seniors, 4th years, were in the cycle of studying for the oral exams. And then it went to the core exam. So the type of studying that my class, that in the 2 other classes ahead of me were doing, was kind of preparing for a multiple choice exam, a little bit different than oral style exam in Louisville. So that has kind of been the trend in, for diagnostic or DR. you're going to kind of be taking a multiple choice exam. For the IR candidates out there, just know that you are going to have the multiple choice, but eventually you're going to have the oral exam, and it's a different kind of style or type of test. And I'm not sure that everybody's kind of preparing for this. You know, maybe practice with a partner. Hopefully your home institution is kind of giving some maybe, hey, let's talk about this. Let's kind of think about cases and how you should kind of take a case, almost like what they used to teach back in the days of these hot seat kind of styles, just because we're kind of so inclined to do multiple choice these days.
Yeah,
Yeah,
I could
Chris,
actually, I could comment on that if I could, Chris. This has been commented upon by examiners, the concern that candidates may actually have the knowledge, but they haven't really had the practice in organizing their thoughts and being able to synthesize clinical material and the imaging material and being able to present it in a coherent fashion. And so we've actually had some conversations already with the APDIR, the program directors in interventional radiology, and we're actually having another meeting with them coming up at the AUR. And this is going to be a point of emphasis in the training programs, is to be sure that the trainees are really getting the experience of putting these things together. It's actually an essential skill, because this is what practice is about. I mean, someone comes down to your department and says, hey, I've got this case, and they give you some clinical information. You're trying to put that together with imaging, and you have to be able to logically to be able to sift through that and come up with a conclusion and a recommendation. And so it's not sort of a theoretical, construct. It is actually day-to-day practice. It's much closer than a multiple choice question to day-to-day practice.
Yeah, I wanted to put a word in for not over relying on studying multiple choice questions. Actually, it was going to be, I don't know how Danielle feels about this, but that I think you get in trouble when you're looking at these items and then looking at it as that it's a multiple choice question, as opposed to looking at it like you were just on call looking at a case. In other words, you look at the case, make an assessment, try to find out whether the thing that you thought it was on the list or not, and then answer the question. That's a better way to go than to start by looking at all the answers first and then looking at the question and then trying to figure out, well, are they trying to mess with me? Just remember that all the distractors are plausible. I mean, that's the reason why they're called distractors. So you have to be really, really careful about your approach, and really consider doing it without looking at the answers first. And in that case, I think that there is some utility in going after reviewing cases and synthesizing the information, much like what Dr. Spees was describing for oral boards, that it's not, that process isn't that much different, actually. It's just that the difference is that the one of the potential answers is in front of you. But I've had some of my own residents that are incredibly capable get tripped up by dealing with it like a multiple choice, like looking at it, going, oh, this is what it is, and looking at the answers there, and then going, oh, wait a minute, there's these other possibilities. Could it be that this is too easy? They're trying to mess with me, and instead of just answering the question that they thought that it was, they thought it was too easy, and then get into this mind trap. And we're not trying to mess with people by taking this exam. That's not the purpose of it. It's to determine whether or not you can synthesize the image and get an answer. And it's very similar to the oral boards in that respect. I don't know, does that seem fair, Danielle, or yeah?
I would agree with that, definitely. Yeah, I think that I had received similar advice, thinking about the case and what answer you're going to choose before even looking at the options leads to, a better result and definitely less stress, I would say. Otherwise you can get caught up in going back and forth between several options.
Yeah.
And I think, you know, like as we've been talking about, preparing for the boards by going through cases similar to as to how you might for oral boards, I think is a great strategy. I kind of started my dedicated board review, you know, seriously starting to spend some extra time with virtual AIRP, which I did earlier than some of my classmates in October, and I was very grateful for that. And I think that that is a great time to start looking at cases in that way. I mean, AIRP is very case based, as many of us know. Um, and then kind of using that as a foundation to start preparing, rather than getting too caught up in the multiple choice options. I think so many of us, you know, we've done so many multiple choice tests up to this point with the USMLE and before that college entrance examinations and MCAT, and this is a different test for sure.
Yeah, because 60% of it's just image or images, and then what's the answer?
Great, thank you. Can you speak to the subspecialty exams in neuroradiology, pediatrics, and nuclear radiology? Are they required if you are fellowship trained in these areas?
Well, none of us are peds or neuro or nuclear medicine, nuclear radiology, but they're not required. In fact, no board examinations are required. However, I would strongly recommend that if you're eligible for an examination, take it. It's another measure of your ability as a radiologist, and you'd be wise to take those whenever you're eligible.
Yeah, I would just add that there are certainly some hospitals where that subspecialty certificate is required, mostly in large academic institutions and less so in community hospitals. But there are times when it's a requisite part of being on the medical staff. So although it's, as Dr. Dunning says, the exam itself is not required, it may be a local requirement based on the privileging and credentialing that process that goes through the hospital medical staff. I would also add that there is a time limit, and we run into this every once in a while, where if you were to do one of the ACGME fellowships, neuro, peds, or nukes, that if you don't choose to take the exam and you decide 7 years after the fact, you're going to have to go back for more training. There's a time limit on how, basically, if you're going to sit for the exam, you have to pass it within, I believe it's 6 years. And David, you can correct me if I have that number wrong. Right now, we have waived that temporarily, but the ABMS requires that we actually have a time limit between completion of training and taking the passing the subspecialty exam.
That's right, Dr. Wagner. It's 6 years from the 6 full calendar years from the completion of the fellowship.
David, I think there's a parallel question here listed. Can I work as a general radiologist, for example, doing teleradiology right after you graduate from residency? It really depends upon the employer and what their requirement is. Well, obviously, you have to be licensed in the jurisdiction, but there is not a national requirement to work as a radiologist that you be board certified. However, as Dr. Wagner pointed out, many medical staffs require it, or at least require it within a certain limited period of time after you get done with training. Many, like in our own system, would say within 2 years. I think in the long run, board certification is a huge benefit because there's been a progressive movement in the direction of trying to reinforce certifications and to be able to reassure the public, and that's from the hospital system and the health system's perspective, a valuable thing. So I am aware of many systems that might allow you to start working that way, but over a period of time they put in those requirements, and I don't think anybody wants to be 5-6 years out after training trying to go back and pass a certifying examination as a condition of employment.
Great, thank you. Another question is, what percentage of RISE exam is in the core versus the certifying exam? And I can take that one. There are actually 60 questions on the qualifying core exam that are RISE specific questions. And then there are 10 on the certifying exam. So 70 total, 60 again on the qualifying core exam, and then the remaining 10 are on the certifying exam. Let's see here. Another question. Would the ABR consider partial credit for reasonable answers rather than an obviously wrong answer? And then it says the binary correct or incorrect system fails to recognize when somebody recognizes a case but fails to get it exactly right versus someone who is clueless.
It's a great question. When you're trying to look at that, you're thinking about that single item. And so in a single item, it's true that you can get tripped up and be asked a binary answer. In these cases, it is the opinion of the people that put the exam together that the question is in fact answerable. It doesn't mean that you're going to get all of them correct. So in a given item, you would not, you could be tripped up in the sense of being in the same camp, if you will, as somebody that's clueless, if that's what you're trying to say. You know, go, but look at I was close, and so shouldn't that be better than just being totally clueless? But over the course of 657 items across the entire exam, the likelihood is that people that have a firm understanding of what they're doing are going to pass, and that people that don't pass. So it's the breadth of the exam is what protects you from needing partial credit when you are a person who's competent.
I'll just add, and Don, you alluded to this, that if we had two answers that were that close, that question would be removed from the test.
Yeah.
And the rationale is, I mean, imagine if you're a very good candidate and you look at A and you go, well, I think A is correct, but boy, B is a really good answer. It's problematic to have a question set up in a way where we'll give full credit for A and partial credit for B, because if we put a whole bunch of those on the exam, and people would, be banging their head against their computer because of that closeness. So the idea is there is one correct answer, and it's not perfect. I like the nature of the question because it implies that we often deal with things that are differential diagnosis, but the reality is that in order to be fair, the best we can do is have one that clearly is distinctly different from the rest. And obviously that means that we couldn't give partial credit for a wrong answer because we hope is clearly wrong.
That's true on the oral exams too. So there was one correct answer, so.
True.
Yeah.
True. Yeah. Well, that's a good point.
And when there is a question that's like that, where people are literally splitting the answers 50-50 between two answers, it ends up being identified as what's called a problem item, and it ends up being removed from the scoring because it's ended up being problematic. We thought it was a good question, but it turned out that it didn't work out. So
we should also point out that there are people in the ABR office staff who are expert in item writing, and they go over those items rigorously and make sure that there aren't leading clues or misleading clues on each item. So they're made up by volunteers, but then reviewed by item writers with those special skills. So we think by and large, the questions are quite good. If one slips through that doesn't work, it's removed.
And I think that the other thing that's understanding is the amount of filtering that goes on. The item writing committee writes it, goes over, it's adjusted if the committee doesn't think it's right. Then when a form is put together for that specialty, it's looked at again and they go, geez, why did we even, if there was a problem, they look at it again and go, why did we even approve this item? This isn't, this isn't good. Let's go look at another one. So that's another thing that happens. And then we do a process called test assembly, where it's a room full of people from the multiple specialties. And they're looking at the exam in its entirety to try to ensure that there's a broadness to the exam, that we're not overemphasizing certain concepts. And then it could be people like a chest radiologist looking at a musculoskeletal question and saying, are you serious? That's what you expect a person finishing 3 years of training to know? You know, that's too hard. You need to replace that item, and then those items get replaced. So there's 3 levels of viewing that to try to make this exam as absolutely fair as possible. It has to be a high standard, but it also has to be fair to try to take those questions that are just absolutely too close, that was being alluded to earlier.
There actually is a final stage beyond that in which the trustee or the associate executive director will review each of those forms in a separate process before they're deployed. So this probably goes through 4 to 5, you know, including the editing levels. Having said that, it is not, you know, it's not rare. It's unusual that we get bad items, but sometimes, you know, in retrospect, you see the question is written in a way where it's not completely clear, etc. And that's where the assessment by the psychometrics group comes in, and they look at that and they say, well, this item didn't perform, and they'll just no score it, or they will at least remove it from future use. So it's a pretty rigorous process, not perfect, but pretty rigorous.
Yeah. That's one of the hazards of having multiple choice questions written by your faculty as a board review process, is that the same kind of rigor wasn't established. And so you can get misled in terms of what the exam might look like. So you have to be really careful for that. The practice examination is a much a closer approximation of what the exam's going to look like.
Great insight. Thank you. Well, we are at the top of the hour and the end of the session time. It's been great. Really appreciate everybody that's taken the time to join us. Much appreciation to all of you that have joined as panelists. Any final words or information that you want to impart before we close things out? Anyone? Any of the panelists?
Study hard. Be good at what you
Alrighty.
do. Yeah.
Thanks again, and we appreciate everybody participating.
Thank you.
Thank you.
Thanks.